everyone to Neuroism.
My name is Dr. Nick.
And my name is Dr. Lee.
In this video, we will illustrate a neurological case in about 5 minutes.
We are offering summaries and notes that are simple and easy to understand,
helping you to learn and boost your memories of the topic.
So let's get started now.
Guillain-Barré syndrome was discovered in 1916 by 3 French physicians. They described 2 French soldiers with motor weakness, paresthesia, areflexia, with albuminocytologic dissociation in cerebrospinal fluid and diminished deep tendon reflexes.
This syndrome is a rare autoimmune neurological disorder in which a person's immune system mistakenly attacks part of their peripheral nervous system, causing an inflammatory demyelinating polyradiculoneuropathies. In Guillain-Barré syndrome, or the acute forms, the maximal deficits develop over days or weeks, with a maximum 4 weeks, followed by a plateau phase and gradual recovery, while the chronic forms pursue either a slowly progressive, 2 months or more, or a relapsing remitting course. The cause of Guillain-Barré syndrome is incompletely understood. There is evidence that it is immune-mediated. The immune attack in this syndrome is widespread and occurs proximally at the nerve roots and distally at the motor axon terminal. These 2 sites are theoretically more vulnerable because of their less complete blood-nerve barriers.
The immune system probably being altered as it responds to foreign molecules, such as a virus or bacteria. Later, the immune system inappropriately attacks host tissue that shares homologous epitopes, for example, gangliosides, which are found on the cell wall of certain bacteria and the peripheral nerve myelin of the host. This pathologic process has been termed molecular mimicry. Next, lymphocytes and macrophages are involved in damaging myelin and the adjacent axons that lead to the action potential conduction block, secondary to demyelination or conduction failure due to axon damage.
The Guillain-Barré syndrome often appears 1 to 3 weeks after symptoms of a viral upper respiratory or gastrointestinal infection. The earliest clinical presentation begins with sensory symptoms, especially paresthesias, beginning distally, usually in the toes and feet, ascending through the lower extremities and later the upper extremities.
The major clinical manifestation is a progressive weakness that evolves more or less symmetrically over several days to weeks, with a maximum 4 weeks.
The proximal as well as distal muscles of the limbs are both involved, usually start from the lower extremities before the upper, corresponding to ascending paralysis. The trunk, neck, facial, oropharyngeal muscles and in severe cases respiratory muscles may be affected later. While on the examination the areflexia or hyperreflexia is usually present. The autonomic dysfunction, including orthostatic hypotension, labile blood pressure, tachyarrhythmia and bradyarrhythmia, is frequent in more severe cases and an important cause of morbidity and mortality.
In recent years, it has been recognized that not all Guillain-Barré syndrome cases are due to acute demyelination. An axonal immune-mediated injury may also produce a similar clinical presentation. The first axonal subtype is called acute motor sensory axonal neuropathy because of involvement of both motor and sensory fibers. The second subtype is called acute motor axonal neuropathy, which purely involve motor fibers only. Another infamous variant is Miller-Fisher syndrome, that is characterized by the triad of ophthalmoplegia, ataxia, and areflexia.
The diagnosis of Guillain-Barré syndrome depends on clinical criteria supported by electrophysiological studies and cerebrospinal fluid findings. The cerebrospinal fluid protein content is elevated in most patients with Guillain-Barré syndrome, whereas the cerebrospinal fluid cell count is usually normal. The dissociation between high protein and low numbers of cells has been given the descriptor albuminocytologic dissociation. In Guillain-Barré syndrome, the motor and sensory conduction velocities are abnormally slow, with prolonged distal motor and F-wave latencies, and often absent H reflexes. The Ho criteria introduced the temporal dispersion, whereas the Haddon criteria introduced the concept of conduction block in Guillain-Barré syndrome.
The treatment of Guillain-Barré syndrome consists of general supportive management and early specific treatment such as intravenous immunoglobulin or plasma exchange. During the progressive phase, patients should be closely monitored for respiratory and bulbar function, ability to handle secretions, heart rate, and blood pressure. Respiratory failure is common in Guillain-Barré syndrome. In about 1/3 of patients require mechanical ventilation. We can use a clinical prediction model, the Erasmus Guillain-Barré syndrome respiratory insufficiency score, to predict the probability of respiratory insufficiency within the first week of admission.
In severe cases, the specific treatment to counter the autoimmune attack is highly effective if given within 1 to 2 weeks after the onset. The American Academy of Neurology released guidelines stating that treatment with plasma exchange or intravenous immunoglobulin hastens recovery from Guillain-Barré syndrome. Hence, combining the two treatments is not recommended. The intravenous immunoglobulin is given as a 0.4 grams per kilograms over 5 consecutive days, while the plasma exchange is given as 5 times of 1 plasma volume, each over 9 to 10 days. Lastly, the usage of injection or oral steroids are not effective for Guillain-Barré syndrome.
Well, that's complete our video about Guillain-Barré syndrome.
And we hope this video can help you completely understand this syndrome.
If you like this kind of content, please kindly click on the like button.
Share this video with your friends.
And don't forget to subscribe to our channel. Ciao!